Kansas and in Kansas City, Kansas. And I am currently the state chair for the Commission on Cancer through the American College of Surgeons. And so as part of that role, we developed a few years ago these quarterly webinars. They're over a variety of topics. Initially, these were offered to only sites throughout Kansas who had Commission on Cancer designation. And then we really felt like this would be a fantastic resource for all surgeons throughout the Kansas chapter of the College of Surgeons, and really for everyone in those practices and everyone throughout the state of Kansas. So we really opened this up to all those who are interested. And so we're thrilled that you could all be with us today. It's my pleasure. This is going to be, I think, a fantastic talk. I'm really excited to have our speakers tonight. Colleen Bonenkamp, who's a PharmD at the University of Kansas Health System, Dr. Kelsey Larson, one of our breast surgical oncologists, and Dr. Ann O'Day, one of our medical oncologists. And really, Dr. Larson was key in setting this up this evening. So I have the pleasure of introducing her, and then she's going to introduce her colleagues more thoroughly. So Dr. Larson is a breast surgical oncologist and assistant professor of surgery at the University of Kansas Health System. She is a fellow of both the American College of Surgeons and the Society for Surgical Oncology. She is the current NAPBC committee chair for KU Cancer Center, the program director for the SSO approved Breast Surgical Oncology Fellowship, chair of the Surgery Research Committee, and immediate past president of the Kansas chapter of the American College of Surgeons. She serves on the Selected Readings Committee for the American Society of Breast Surgeons, as well as the Education Committee nationally for the Commission on Cancer. I've had the pleasure of getting to know and work with Dr. Larson more frequently through my combined practice, both at Topeka and Kansas City. And she came to me one day and was so excited. She said, we just had this great talk and discussion about these advances in adjuvant therapies and their perioperative complications. She was like, it was so great. We've got to roll this out to everyone else in the state. This is exactly what they need to hear. It was perfect. And I have to say that as a community general surgeon, Dr. Larson is everything you would hope for in an academic partner. She clearly has a passion for breast cancer care and research, but also in education. And truly her focus is centered on the best care for her patients, but then also the best care for all those in our state. So I am thrilled to have her join us this evening, and so thankful for her organizing this talk for us tonight. So with that, I'll turn it over to Dr. Larson.
Well, it's wonderful to have everyone here, and Jen is absolutely correct. I was so excited because Dr. O'Day and Colleen actually gave this talk to our center as part of an invited conversation through NAPBC for some quality improvement things we're working on. And really this talk generated, I think, a lot of engagement within the multidisciplinary team about these newer systemic therapies that are coming out and how they impact not just the medical oncologists in terms of understanding and knowing the medications, but also the surgeons, the radiation oncologists, the plastic surgeons, everyone. So I really thought that this was a great opportunity for us to share with a wider audience. And just to let you know, Dr. O'Day had some of her practice in Hays, Kansas, if I'm not mistaken. And so she and I both, I think, share a passion for wanting to make sure that we are supporting patients wherever they want to receive care all across the state of Kansas, and really want to be liaisons and be offer to be contacts for anyone across the state, wherever you might be, who wants to talk about a patient or go through a scenario or talk to us about care or surgery or the medical side of things. And so please keep our names. Please make sure that you know that you're invited anytime to reach out to us. So how we have set up this fun interactive event today is that Dr. O'Day and Colleen are going to share a lot of great information about some of these newer systemic therapies, and then we're going to pause from the information on the slides and talk about how we are incorporating or maybe meeting some challenges, incorporating this with our surgery patients. And so we're going to go through 1 to 2 medications for a couple different subtypes of breast cancer. So a few slides about the medications, and then really want it to be a group conversation. So when we're talking about our challenges, please feel free to interrupt, chime in, ask questions. We would love for this to be interactive.
Perfect. And I think with that, we will go ahead and get started.
As Dr. Larson said, we really would like for this to be as interactive as possible. And so if you all do have pertinent, you're thinking of a patient in your own practice or a clinical situation that sounds familiar and that you'd like to expand on, absolutely speak up. We are just gonna, there we go. All right, so we're gonna start out tonight with, I think, where is the most advancement, and that is in our patients with hormone positive and HER2 negative breast cancer, because there has been recent approval of a whole new class of drugs, the adjuvant CDK4/6 inhibitors, in abemaciclib, and we expect to be approved any day ribociclib. So we'll start out with that conversation. Then we'll move on to our patients with HER2 positive breast cancer. Then we will touch on our patients that have a germline mutation in BRCA in terms of an adjuvant PARP inhibitor, and then touch lastly on our triple negative patient population with adjuvant immunotherapy with pembrolizumab. And that will be where we will end up tonight. All right, so we're going to start off and frame this in the context of a patient. This is a patient that we took directly from our own practice. Hopefully this reminds you of a clinical scenario that you may have encountered. So this is a relatively young patient, 42 years old. She is premenopausal, and she has a right breast cancer that measures just over 3 centimeters. It is grade 3, and it has high estrogen receptor expression, lower progesterone receptor expression, and she has 2 positive axillary nodes. So she is treated with neoadjuvant chemotherapy with an anthracycline and taxane based regimen. And the plan is for her to undergo mastectomy and reconstruction eventually. So when we think through the data that we'll talk through, we want to frame that in the context of what is her optimal adjuvant therapy. We understand that she's at relatively high risk of recurrence. She's premenopausal, has a high grade positive axillary nodal breast cancer. And so we want to make sure that we give her every possible chance to achieve a cure. So what is going to be her optimal adjuvant therapy, surgical management and adjuvant therapy that will let us help her achieve that? And how does that adjuvant therapy, what implications does that have for her surgical management and specifically reconstructive management, as we were discussing? So just to touch a little bit on this class of drugs, the CDK4/6 inhibitors, these previously had been approved by the FDA for women with hormone positive, HER2 negative advanced breast cancer. The first one was approved in 2015. And so we have had these medicines, of which there are 3. We have had them around since at least 2015. So many of you may be familiar with them and seen the names in your medical records in the context of patients with advanced breast cancer. But only recently, in October of 2021, so not quite 2 years ago, we had the first approval for an adjuvant therapy with a CDK4/6 inhibitor. This was abemaciclib, also known as Verzenio. And I think now maybe you're hearing about these drugs more. They're now advertised on TV for early stage breast cancer patients in addition to metastatic breast cancer patients. Sometimes that causes confusion and distress amongst patients. But they do now have a commercial. I've seen it on CNN and other places for adjuvant abemaciclib or Verzenio. It's approved in combination with endocrine therapy. So whether that's tamoxifen or an aromatase inhibitor, for the adjuvant treatment of patients that have hormone positive, HER2 negative, node positive, early breast cancer at high risk of recurrence. Importantly, just this past ASCO, just a month or so ago, we had the presentation of the NATALEE clinical trial, of which we were lucky enough to participate at KU. I had many patients on this study. And this was a similar sort of patient population, but looking at an adjuvant CDK4/6 inhibitor known as ribociclib or Kisqali, the brand name. This data was presented just a couple of months ago, and based on this data, which we'll show you in a bit, we anticipate that this drug will become approved in the next several months. So whether you see abemaciclib or ribociclib, we want you to be familiar with those and kind of understand a little bit more about those. And so with that, I'm going to ask Colleen to walk us through kind of the mechanism of action so that we can understand a little bit more about the toxicity profile of this class of medications.
Hi, thank you. I'm Colleen. I'm one of the clinical pharmacists at KU. So I have the pleasure of discussing drug mechanism of action. I think it's best learned by a picture. I promise not to delve too deep into this, but I want to highlight a few things. So if you follow the picture on the left, I want to point out from this picture that if you look in the center in that blue circle, you'll see CDK4/6 and cyclin D located there. And so what this is telling me is that this is located in the nucleus of the cell where these drugs exert their mechanism. Then if you follow the picture over to the left, I'm sorry, I want to back up. I should say that this cyclin D and CDK4/6 compound is located downstream from the PI3 kinase, AKT, and mTOR pathway, for which we already have commercially available drugs in the metastatic setting. Namely, here you can see alpelisib and everolimus. Then if you move to the left, you can see specifically where the CDK enzyme works. So basically what this enzyme does is it phosphorylates the retinoblastoma protein, which really doesn't mean anything to anyone. And that's not really a memorable way to remember this. But what I like to think of is this being a specific checkpoint in the cell cycle. And I like to think of the cell cycle as kind of like a bicycle tire. And there's certain breaks along the way or checkpoints to prevent things from accelerating too fast through the cell cycle. And then there's these checkpoints that cause breaks. And there's also things that cause faster cell division. And one of these things we can see is estrogen. So estrogen has been shown to increase progression through the cell cycle, and it's specifically at the CDK4/6 checkpoint. And so if we administer a CDK4/6 inhibitor in combination with endocrine therapy, what we're doing is essentially pumping the brakes on that cell cycle and preventing the cancer cells from growing and dividing. The other point I want to make on this slide is how Verzenio or abemaciclib differs slightly from the other commercially available CDK4/6 inhibitors. So abemaciclib is more specific to the CDK4 enzyme than the CDK6 enzyme. And CDK4 is more involved in tumorigenesis and tumor cell growth, whereas CDK6 is more involved in hematopoietic stem cell differentiation. So what this means in a practical standpoint is that since abemaciclib is more specific to the CDK4, it doesn't cause as much cytopenias as we see with the other two CDK4/6 inhibitors. So it can be dosed on a daily basis versus ribociclib and the other CDK4/6 inhibitor palbociclib are dosed for 3 weeks on and 1 week off. And then the last point I wanted to make is since the way that this works, essentially like pumping the brakes, it's pausing cell replication, it's considered a cytostatic medication. So if we stop the medication or reduce the dose, we see a much faster hematologic recovery than we do with traditional chemotherapy, which is a cytotoxic medication. Next slide, please.
Perfect. Okay. Thank you so much, Colleen. I think that sets kind of the framework. We're going to talk about briefly the clinical trials that led to the approval of these drugs and kind of the evidence that supports their use. So the first trial is the monarchE trial, and this is what led to the approval of the adjuvant use of abemaciclib in combination with endocrine therapy for these high-risk node-positive patients. So just to understand who these patients are for the monarchE trial, importantly, these are all node-positive patients. This was a very large international open label phase 3 trial. It was divided into 2 cohorts, and I don't think that is as important for you to understand, except for to understand a little bit more about who these patients were. So in one of the cohorts, we had patients that had 4 or more positive axillary lymph nodes, or if they had 1 or 2 or 3 lymph nodes, they had to also have another high risk pathologic feature within their cancer. So that could have been, it could have been a high grade cancer, grade 3, or a tumor of at least 5 or more centimeters. And that is really the group of patients that the drug has been mostly adopted and used in. And patients received abemaciclib, which, as Colleen mentioned, is given on a daily dosing schedule. It's 150 milligrams twice a day for up to 2 years. The goal is to take the therapy for 2 years in combination with the patient's prescribed endocrine therapy, whatever that standard of care endocrine therapy is, for 5 to 10 years as clinically indicated. Just under 3,000 patients were randomized to the abemaciclib arm compared to just under 3,000 patients that received abemaciclib alone. And the primary endpoint here was invasive disease-free survival. What we see in the IDFS results is clearly we can see the group of patients that received the abemaciclib in combination with the endocrine therapy, which are represented by the blue line, did better than the patients in the red line. Now, importantly, these curves don't separate. I draw your attention here to about the 12 to 15 month mark, at which time the curves really start to separate. I think that is representative of this particular patient cohort. That is, these are hormone positive breast cancer patients. We don't typically see very early recurrences. It takes a few months for patients to have recurrence for enough events to be documented so that we can actually start to see a separation in these curves. So when the data was presented, the IDFS rate at 2 years, so this was the 2-year data, this was the data that led to the accelerated approval, was 92.2% for the patients that received the abemaciclib, or 88.7% for the patients that received endocrine therapy alone. Now, if we look at the subgroup analysis, remember, these are all very high-risk patients. All of the subgroups really seem to benefit from the addition of abemaciclib. There really wasn't a subgroup of patients that we would say did not get the benefit. And if we look at distant recurrence-free survival, which we all care about local regional recurrences, certainly we do, and we want to prevent those. But we know that a distant recurrence is going to be a fatal recurrence for that patient. And so looking at trying to prevent distant recurrence-free survival is perhaps a meaningful clinical outcome for patients. It may actually motivate them to want to take a medication for 2 years or not, depending on that. And so in the distant recurrence-free survival, remember, this is the 2-year data, we saw 93.6 compared to 90.3 for the patients that received abemaciclib. Now, when we look at side effects, when we look at toxicity profile, when we think about abemaciclib, as Colleen mentioned, this is more selective for cyclin D4 versus 6. And so we see a different toxicity profile than we do with the other CDK4/6 inhibitors. First and foremost, we talk about GI toxicity with this drug. You see here that a majority of the patients did experience some degree of diarrhea. And that's important. We have a drug that we want patients to take for 2 years. So it's very important for us to be able to manage this, understand this. There can even be some implications for our surgical colleagues, because if patients are having bad diarrhea, they're getting dehydrated, having electrolyte abnormalities, that's something that we have to be on the lookout for and make sure that we're optimizing that when we take those patients to surgery. So you can see here some of the important toxicities kind of lumped together in particular categories, but the majority of the difficulty, I can tell you from a practical perspective with abemaciclib, comes in terms of the GI toxicity, and that is the primary reason for discontinuation. Importantly, there were some deaths in this trial, but it was 0.5% of patients on either arm, so it didn't seem to be a significant difference. We don't see alopecia with this drug. We can see some slight elevation of LFTs. It does slightly increase the risk for a venous thromboembolic event, and there can be some interstitial lung disease as well. So all things that we need to be aware of. As far as grade 3 adverse events, occurred in about 50% of the patients that received abemaciclib, compared to only 13% of patients in the control arm. So important for us to be able to manage the toxicity profile for this patient. More patients obviously discontinued therapy in the abemaciclib arm. Importantly, although the difference was significant when it first came out, and we were all very excited about this, we were much more impressed when we saw the updated 4-year invasive disease-free survival results. And this shows an even greater benefit. We now are in the kind of over 6 to 7% range. So 79.4% invasive disease-free survival for the patients that got endocrine therapy alone, and compared to almost 86% for the patients that received the abemaciclib in combination with the endocrine therapy. So I think when this data was presented, anybody that was waiting in the wings, that was kind of a naysayer, that was kind of waiting back to see, is this drug really worth it? Will the curves come together with longer follow-up? We now know that that is not the case. In fact, there is greater separation. It seems that the benefit appears greater with the longer duration of follow-up. So this really has changed the standard of care for our patients with hormone positive, lymph node positive, high risk breast cancer in the adjuvant setting. Because of this data, the ASCO guidelines, which is sort of our Bible as a medical oncologist, the ASCO guidelines were updated in 2021 to suggest that 2 years of adjuvant abemaciclib in combination with endocrine therapy should or could be offered to patients that have hormone positive, HER2 negative, node positive early breast cancer that have a high risk of recurrence. And they defined the high risk of recurrence just like the eligibility criteria for the trial. That is, if patients had 4 or more lymph nodes, those patients are kind of a no-brainer. All of those patients, we would offer adjuvant abemaciclib. If they have a less degree of nodal burden, so 1 or 2 or 3 lymph nodes, and grade 3 disease or a larger tumor, we would also consider offering this for these patients as well. Now, importantly, the FDA updated their approval in March of 2023, and they removed this Ki-67 requirement. So that made it nice for us. We weren't having to go back and chase down Ki-67s on patients. So now we're looking for positive lymph nodes, lots of positive lymph nodes, or a few positive lymph nodes and grade 3, or a tumor that's a larger tumor. So that's kind of where the guidelines are currently. Colleen, do you want to comment a little bit on some of the radiation and surgical considerations?
Yes, yeah. So I'll circle back just to some practical uses of these medications. So when we're utilizing these, we're using them in the adjuvant setting, both abemaciclib and ribociclib. Patients need to have completed their adjuvant radiation therapy if they are going to undergo radiation therapy. So it's something we'd start after that. As far as surgical considerations, as I mentioned, abemaciclib causes a lesser degree of bone marrow suppression, but we can still see it occur. So that's something to be very mindful of perioperatively if any other procedures need to be done after the initial surgery. And then the last thing I wanted to point out is, and it's not on the slide, but there was a slightly higher incidence of VTE that occurred in the patients that were in the combination of the Verzenio and endocrine therapy arm. I think it was like 2.5% versus 0.7% in the endocrine therapy alone arm. So in any patient that's going to be at a higher risk of VTE, just be mindful that there is a slightly higher risk of that. And then the other question I often get asked as a pharmacist is, how long do I need to hold these medications surrounding surgery? And there's no clear guidance specifically in the package insert for any of the CDK4/6 inhibitors specifically. What I look at the very least is a drug half-life. And a general rule of thumb is you want to hold a medication at least 5 half-lives to consider it completely eliminated from your system. So you can see the drug half-life here is about 18 hours, which 5 drug half-life is about 4 days. So at the very least, you would want to hold it at least 4 days, but most people are going to be more conservative than that, and you may want to hold it longer. And then I just had the adverse effects, which Dr. O'Day mentioned previously. So we can go to the next slide.
Perfect. Thank you. Thank you so much, Colleen. So the second CDK4/6 inhibitor, this data again just presented last month in Chicago, was the NATALEE clinical trial. And this was the trial that looked at adjuvant ribociclib in combination with endocrine therapy and hormone receptor positive HER2 negative early breast cancer. Now the patient population here is different. And so we start now expanding on the potential, in other words, the number of patients that potentially might start receiving these adjuvant CDK4/6 inhibitors. So these are patients now that have node positive disease, or if they're lymph node negative, they could have other high-risk features, such as grade 3, or they could have grade 2 and other high-risk features, such as elevated Ki-67, a high oncotype score, and high risk via other genomic profiling, such as MammaPrint or something like that. And patients that were considered anatomical stage 2B or 3 would all be eligible. So now we have widened the sort of the net for the number of patients that might be treated with these drugs. We're now having to consider this for patients that are node negative. Now, I should mention this drug is not yet FDA approved. So as of this moment, we aren't able to prescribe this drug outside of a clinical trial. However, we expect that approval to come imminently. So we thought we should include it here today so that you guys will be prepared in the months to come when you see your patients in your practices. So in this trial, patients were randomized in a 1-to-1 fashion to receive ribociclib. And as Colleen mentioned, this agent is dosed differently. It's in a 3 weeks on, 1 week off schedule in combination with an aromatase inhibitor for 5 years in combination with goserelin in men and premenopausal women. Or patients received AI monotherapy and ovarian suppression. Now, it's important to understand here, what you don't see is tamoxifen. So this drug is not given with tamoxifen because of a potential safety consideration. And so we don't routinely prescribe tamoxifen in combination with ribociclib. If we have a patient that needs ribociclib, we want to make sure that that patient can have their endocrine therapy in the form of an aromatase inhibitor. Again, the primary endpoint, similar to the last trial, was invasive disease-free survival. We see here the baseline characteristics. It was a pretty even split between postmenopausal women and men and premenopausal women. The majority of the patients, 60% of them were stage 3. You see the lymph node, the majority of the patients were actually N1. There was a number of patients that were node negative. And these are patients we know are high risk because if we look at the number of them that received neoadjuvant or adjuvant chemotherapy, it's almost 90%. So these are patients that we would all deem high risk and fit enough to receive chemotherapy. The median follow-up that we have for NATALEE so far is 34 months. The majority of the patients are still on ongoing treatment. So this is like a preliminary data look, a peek into the data once a defined number of events have occurred. We look at the patients that have completed ribociclib. 2 years of ribociclib includes the ongoing is 57%, and 3 years of ribociclib is 20%. And please forgive me for not mentioning that this drug, different from the abemaciclib, which is 2 years, in this trial, it was for 3 years. So we have a 2-year medication versus a 3-year medication. So very different implications, of course, for us in terms of the follow-up. When we look at the interim analysis, you can see the hazard ratio here in favor of the patients that received the adjuvant ribociclib at 0.748 with a p-value of 0.0014. We're starting to see a separation in those curves, although we would all admit it is early, and many of us have said we would like to see longer follow-up, although we expect to see a similar trend as we did with the abemaciclib. As far as radiation considerations, again, as Colleen mentioned, we want to make sure that radiation is completed prior to initiating ribociclib. As far as the surgical considerations, as we mentioned, this drug has more cytopenias. So we see more neutropenia, more anemia and thrombocytopenia. We also know that this drug can be associated with prolongation of the QT interval and actually requires monitoring of regular EKGs. So that's something that we build into the follow-up as medical oncologists, and is something that I think that you all, as people that could be putting people under anesthesia or taking them to the OR, it's also something that you should be aware of. There's really no specific guidance as far as the recommendations, as far as the holding the medication, but we do want to make sure we avoid the nadiring of the white blood cell count around the time of surgery. We usually want to hold it for 7 days prior to surgery and up to 3 weeks post-operatively based on wound healing and recovery. Although there is no hard and fast guidelines about this, in the clinical trial, they did not require that the agents be held for any surgical procedure. So that's going to vary by institution and by provider, and something I would encourage you all amongst your multidisciplinary teams to sort of discuss. The half-life here is longer, somewhere between 30 to 55 hours. So again, a little bit longer, suggesting that we may want to do a little bit longer hold. What I did for my patients that were on this study during the clinical trial, when the trial was ongoing, is that we would make sure that their surgery kind of fell during that off week. So preferably at the end of the off week of their medication. And we usually would hold it for 1 additional week prior, so that the patient would get like a 2-week break prior to having a surgical procedure. Because this drug has that week break period built in, it gives you some natural ability to sort of hold the drug prior to any surgical procedure. And when we look at the adverse events, you see more neutropenia than what we saw with the abemaciclib. Liver-related adverse events, there can be some liver toxicity with this agent, and we do have to monitor liver functions. As I mentioned, the QT prolongation, higher in the ribociclib arm, but again, very low numbers here, but it is something that has been reported. And as I mentioned with the abemaciclib, this is a class effect. There can rarely be some patients with interstitial lung disease or pneumonitis. So we have this nice table that sort of compares the 2 different trials and the 2 different patient populations. So if we think about putting this data sort of together between the NATALEE and monarchE, the patients that might be eligible for an adjuvant CDK4/6 inhibitor, you can see here the patients that there is, a wide range of patients that potentially could be eligible. So when we have the patients in green, all of those patients, of course, would be eligible. The yellow are the ones where they're potentials, like if they have a high oncotype, for example, or a high Ki67, If you look for Monarch E, as I mentioned, if they have a high grade tumor, potentially with a lesser number of lymph nodes, or a T2N1 tumor, again, grade 3, those patients could be eligible. So that is just something to keep in mind. This kind of gives us a little bit of comparison and have us understand that NATALEE certainly encompassed a broader range of patients. As we mentioned, these were patients that some of them didn't even have positive lymph nodes. So definitely you can see that this is a very high percentage of the number of patients that we encounter in our breast cancer practices. So let's put this back in the context of our patient case and remind ourselves about our 42-year-old premenopausal woman with a right breast cancer, 3.4 centimeters, that's grade 3. We've highlighted that for you there to make it easy for you. She's hormone positive and she has 2 positive axillary nodes. She had neoadjuvant chemotherapy and she's planning for mastectomy and reconstruction. And so when we think through what is her optimal adjuvant therapy, right away, we're thinking about that this is a person, because she does have positive lymph nodes and because she has another high risk feature in the terms of grade 3 cancer, not to mention she's premenopausal. We're thinking that this is a patient that very likely would be eligible and that we would have a discussion about the risks and benefits of adjuvant CDK4/6 inhibitor therapy. And so based on that, we do want to kind of have a little bit of a discussion about how that impacts our surgical colleagues and particularly also our reconstructive surgical colleagues.
So I think one of the challenges that we have found just focusing on the surgical side of things with these patients is specifically as it relates to reconstruction. So when you are working with a patient like this, clearly you are going to be doing a breast surgery and an axillary surgical staging, right? So these patients, especially the younger patients who may be interested in the mastectomy and reconstruction, most of our plastic surgery colleagues are going to start with a tissue expander. Fewer of our plastic surgery colleagues may consider direct to implant. No of our plastic surgery colleagues are going to do direct to deeps, right? Immediate deeps. So now I have a patient who is young, who wants to go to surgery, who wants to plan for a mastectomy. I'm expecting really that she's going to get a tissue expander and need additional steps in her reconstruction. But I'm also expecting from a cancer standpoint that she is going to be recommended to have a medication for 2 to 3 years after her mastectomy. And the problem is, while there is information about how someone may consider pausing it for the purposes of a safe surgery, there is zero information on how any pauses, meaning at what time and the frequency of these pauses, may impact a patient's cancer outcomes. So here we are very cognizant and very aware and honestly kind of stressing about what we're supposed to be doing and actively, robustly discussing what is the best thing to do. Because the question comes up, is it okay to have short pauses in these medications during the 2 to 3 years post-op so that patients can move on with their reconstruction? Because tissue expanders are not fun, they're not comfortable, no one wants to keep them. Or is this going to be detrimental and really risky from a cancer standpoint? And so I would say that we do not have a clear answer for what we always do right now. We do really stress to patients about the importance of the cancer care and the importance of the cancer outcomes, and that we don't have data on this. And basically we try to have a conversation between the medical oncologists, the surgical oncologists, and the plastic surgeons about the timing. But I will say, when asked my opinion, I tell patients my opinion is cancer comes first. And I think that that is a really hard thing for patients to consider, having a tissue expander for 2 to 3 years. So we see our role as to be kind of the liaison on both sides. So we go to the medical oncologist and we say, are you really sure? Is she really actually really high risk that you can't pause it? And then we go back the other way to the plastic surgeons and we say, I think it's time that you need to start considering more patients being direct to implant candidates. and how you can incorporate that more into your practice so someone is not living with a tissue expander for 2 to 3 years.
And I think importantly, setting the stage early on with what is that patient's goals. Like if you know if that patient upfront wants a DIEP flap, we know that we have more concern about wound healing and all of that sort of thing with these medications with a DIEP flap than we would with a simple, perhaps tissue expander for implant exchange. So if the patient's goal is implants, as a medical oncologist, I don't worry as much because I know I might have to only pause my potentially curative therapy for a few weeks, assuming that the patient is low risk for postoperative complications, low risk for infection, and that we're able to minimize the amount of break time. However, we have encountered patients that are adamant about going for DIEP and going right away, and they go soon, and then we have a really significant complication, and we end up with a wound vac and on IV antibiotics for 3 to 6 months. And then all during that time, that patient is not getting optimal curative cancer medicine. Does that kind of make sense to everyone? So that's kind of the balance, is we're trying to decide how high risk is the patient in terms of risk of recurrence of their cancer versus what are their goals for their reconstruction. And we really, my biggest request of my plastic surgeon colleagues is please just be very forthright with setting expectations with these patients. In other words, don't promise this patient, I'm going to do your DIEP flap 3 months after your surgery, because what if that patient is found to have 14 positive lymph nodes and we're really concerned about pausing their curative therapy for a significant period of time, particularly if they were to get a complication with wound healing. So I think that's kind of where the discussion has come in. And there's been a question coming through the chat. Are complete clinical responses seen frequently with this treatment? And does that change the surgical approach? So it's a great question. Right now, these drugs are not approved in the neoadjuvant setting. And so all of these drugs would be given based on their surgical pathologic stage at the time of their definitive surgery. So these are all drugs that would be happening in the adjuvant setting. So there really isn't, at least by a standard of care, we aren't using these drugs in the neoadjuvant setting, at least currently. That may change, but that's a great question.
What I would say, or what I would comment on in response to that is, let's say this patient who's on the screen, she starts out with a 3.5 centimeter tumor, she goes and gets neoadjuvant. And let's talk about the breast only. So we all know that one of the things that happens with the neoadjuvant treatment is then hopefully there's an imaging response so that patients can be better candidates for breast conservation. I personally very much support and promote breast conservation in my patients in general, if they are candidates for that, but in particular with these patients who are candidates, who may be thinking about mastectomy with reconstruction, I want them to understand what the timeline will be and what the process will be. Because on one hand, we can consider, and we have the same clinical outcomes, a lumpectomy. Or on the other hand, they need to know that their reconstruction may be delayed for 2 to 3 years. So I would say for me,
At least interrupted.
Or
Yeah.
at least interrupted.
Yeah.
So for me, I use it as part of my education on lumpectomy and mastectomy and some of the pros and cons, to say, if you need some of these adjuvant treatments that Dr. O'Day might recommend, that is going to disrupt some of the things, likely disrupt some of the things, or could disrupt some of the things in terms of your reconstruction. So we really need to think about, again, why are we choosing mastectomy? And if that is absolutely right for the person, that is certainly their right to choose. However, that is also something that we as surgeons need to continue to remember, that mastectomy does not change recurrence and survival. These medicines do. So I have a really hard time wanting to make sure that my patients understand and are making an informed decision, that you are choosing something that has not been shown to change recurrence and survival, and I will support that. But I am really concerned then if you are considering declining or having large pauses in medicine that has been shown to improve recurrence and survival. That's where I get uncomfortable in wanting to make sure that how I'm advising my patients about their surgical approach gives them the data to make that decision for themselves, if that makes sense. The other thing I wanted to bring up before you move on, not this case exactly, but something for all of our little brains as surgeons to think about. Choosing wisely guidelines, friends. Remember omitting sentinel nodes in those people under the age of 70 with small tumors, and how we all love to do that because we don't like to operate in the axon. We don't want anyone to get lymphedema. This has changed dramatically when we apply choosing wisely, because we have people who are T1N1, right? So in theory, eligible for choosing wisely, T1N1, hormone positive, HER2 negative tumors. And if I find one single positive sentinel node, now they're eligible for something that changes their survival in 4 years, right? 4-year follow-up. So it is a pretty rare circumstance nowadays that we apply choosing wisely guidelines for our patients, unless they have a major comorbidity. So like someone on the liver transplant list, or who has an LVAD or something like that, we will apply it, but it is absolutely not routine within our practice that we are applying choosing wisely because of these new medications and these new approval, because the medical oncologists need the information about the nodes in order to understand if they may be eligible and they may benefit from this. And since these medications are better tolerated and easier for patients, even if they're old with some medical problems to tolerate, they are much easier than traditional chemotherapy. So even if you have a patient who says, I wouldn't do chemo, this is, I call it like chemo light, or I start telling people like immune things. It's really neat. Even though it's not exactly that, because they do really well with these medicines overall. They have side effects like Dr. Ade and Colleen were saying, but they do really well. They can tolerate them. It's not kicking when they're down. So we really hesitate to frequently or commonly apply choosing wisely in omission of sentinel nodes. So I would say that's the biggest thing that has changed within our practice with us.
And I think the biggest thing is just the communication. And if you have the concern about that, or you were considering, omitting surgical nodal sampling, sentinel nodal sampling, then it would be great just to engage your medical oncologist. Is this a person that you might consider adjuvant therapy for, that you need that nodal information, and just engaging the medical oncologist in that conversation. And maybe the medical oncologist says, oh no, this patient has a bunch of cardiac stuff, and so they wouldn't be a candidate for it, or whatever it is. But at least you've created that dialogue, and you're not going to deprive a patient of potentially curative therapy. So Jen says, do you still omit axillary staging in those with high risk features? Without high risk features.
Pretty uncommonly, because if they do not have high risk features such that I may be getting them in or out of this adjuvant systemic therapy, then what I am trying to prove is that they wouldn't need radiation. And so our radiation oncologists are comfortable offering omission of radiation after lumpectomy with negative sentinel nodes. If a patient has omission of axillary staging, it would not be standard of care for them to consider omitting radiation, and they would actually get radiation to their regional nodes or to their axilla. And so do I talk to patients about omission of axillary staging if they have really, really low risk features? Yes, but only if they also understand it will make a difference in their radiation treatment as well. Most patients that we see would rather do the sentinel node and try to get out of radiation. The risk of lymphedema anymore with a sentinel node procedure is somewhere between 1% and 2%. So it's quite low in exchange for having a safe emission of radiation. So I do talk through that, but it's a choosing one or the other.
Fantastic questions though.
Yeah.
Okay, we are going to quickly move on just to cover a couple of other subtypes. I am actually going to fast forward through the HER2 positive data, because I think you all are most familiar with that. The adjuvant TD1 or adjuvant Kadcyla, that has been since about 2019 or so. So I think most of you are familiar with that, and we can certainly take questions on that in the end if you have questions. I do want to quickly touch on our patients with germline BRCA mutations and the approval of olaparib or Lynparza. This is a PARP inhibitor, which was previously approved by the FDA for actually multiple indications, including patients with deleterious germline BRCA mutated HER2 negative metastatic breast cancer. However, now it is approved for patients in the adjuvant setting. And so we just want to make sure that we touch on that. I'm going to turn it over to Colleen to explain this mechanism of PARP inhibition.
And yes, pardon me as I geek out for a little bit. I think the mechanism of PARP inhibitors is so cool. So I think it's important to understand like what's happening in our body normally. So as cells are normally dividing, DNA damage can occur. And the body has two main mechanisms to repair damaged DNA. If you follow on the left, the homologous recombination repair pathway is what's responsible for repairing double-stranded DNA breaks. This can be encoded by several genes. Most notably, we think of BRCA1, BRCA2 genes. Then on the right, you can see the PARP enzyme is responsible for repairing single-stranded DNA breaks. If both of these repair pathways are intact, normal cell replication occurs. Next slide, please. Then from this, you can see if someone has a BRCA1 or BRCA2 mutation, or they are considered homologous recombination deficient, they no longer can effectively repair DNA or double-stranded DNA breaks. And this causes susceptibility to cancer. So we see higher prevalence of breast, ovarian, and other types of cancers. Next slide, please. Now, in a patient that has a BRCA mutation or is considered homologous recombination deficient, if you administer a PARP inhibitor, both the repair pathways for single-stranded and double-stranded DNA breaks are no longer able to repair DNA. So this results in what we term synthetic lethality and results in cell death. And so this is why patients with BRCA mutations or homologous recombination deficiency are the ones that respond most to PARP inhibition. Next slide, please.
So olaparib was approved in March of 2022 for the adjuvant treatment of adult patients that have deleterious or suspected deleterious germline BRCA mutation. Those patients, of course, that are HER2 negative and that have high risk early breast cancer. Now, in this particular trial, they limited it to patients who had been treated with neoadjuvant or adjuvant chemotherapy. So if they weren't high enough risk to receive chemotherapy, in theory, they wouldn't be eligible for the adjuvant PARP inhibitor. One thing I just want to say, if you remember nothing else about this, if we don't test patients for BRCA, we will not know ever if they are eligible for these adjuvant therapies. So please just consider in your high-risk patients, if for no other reason. I actually today in my clinic tested a 68-year-old hormone-positive patient that we just got back her surgical pathology because she ended up having 14 positive lymph nodes. We know that she's high risk and would be eligible for this medication if she has a mutation. However, she didn't meet any of the traditional criteria. She had no family history. She wasn't diagnosed at a young age. But we're coming back now and testing her because we know that it is a biomarker which can predict response to a therapeutic intervention. So just want to put a plug in for testing and thinking about that, especially in your high-risk patients. The trial that led to the approval of the Olympia A trial that led to the approval of olaparib, these were patients that had high-risk HER2 negative breast cancer. So they broke it down into a triple negative cohort and then a hormone positive HER2 negative cohort. Olaparib is given at a dosing which is BID for 1 year. Compared to placebo. And you could see here that there definitely was a difference in the invasive disease-free survival. You can see that difference, the early separation in the curves, which is sustained. All of the subgroups of the patients favored the olaparib compared to the placebo. And importantly, the distant disease-free survival, which we know really translates to cure, it significantly improved distant disease-free survival with a p-value of less than 0.01. Again, important for our patients that have a germline mutation. Colleen, I'll go ahead and turn it over to you and you discuss the half-life.
Yep. So again, this is a medication that we would not give in combination with adjuvant radiation therapy. The half-life of this medication is about 15 hours. So you would want to make sure that you're holding it several days before surgery. And then the biggest side effects we see with this are nausea, anemia, and fatigue. With these medications, we see a lot of the side effects early on in therapy. Specifically, anemia occurs right away and gets better over time. So these are things that patients have better side effects and more tolerance the longer they're on them. Next slide, please.
Thank you, Colleen. So just to touch base also on our patients with triple negative breast cancer, quickly, so we can leave time for discussion. I'm actually going to turn it back over to Colleen and have her discuss the mechanism of action of immunotherapy in the case of pembrolizumab or Keytruda, just so you understand a little bit about how this agent works. But now, as of 2021, it's hard to believe now, it's been 2 years since this was approved, but we have the indication for neoadjuvant and adjuvant immunotherapy in early stage triple negative breast cancer. Previously, immunotherapy only approved in the metastatic setting. So Colleen, I'll turn it over to you.
And pembrolizumab, it's in a class of medication. It's an immune checkpoint inhibitor. It's immunotherapy. Everyone knows about this from commercials and all the other disease states. So under normal circumstances, your immune system or the T cells are seeking out foreign antigens, be it a cancer cell, a virus, a bacteria, and they're seeking to kill those cells. However, cancer cells have gotten really smart, and so they've developed a way to inactivate T cells by having or expressing a PD-L1 receptor on the cancer cell. And so from the picture on the left, you can see that when PD-L1 on the cancer cell is bound to PD-1 on the T cell, it renders this T cell inactive. So basically puts it to sleep. But if you administer a PD-1 inhibitor, a PD-L1 inhibitor, from the picture on the right, you can see that this T cell remains active and then can exert its normal immune system effects. Next slide. So pembrolizumab, the big thing to know about this one is it can be given in combination with radiation therapy, which is what we haven't seen with any of the other medications. And it can also, it does not cause any myelosuppression. It has a really, really long half-life. So you can see here 22 days. So you don't need to wash out around the time of surgery or surrounding surgery. This is given neoadjuvantly. So it is given 3 to 6 weeks before surgical procedures and then can be resumed safely afterward without risk of myelosuppression. What I do want to point out is there is a temporal relationship between the onset of certain side effects from this medication that we can see. So from the bottom on the graph, the yellow and red line, you can see the first side effects we see from this are rash and liver toxicity, followed shortly after with diarrhea. Then the gray line you can see is hypophysitis. And with this, I'll even add like hypothyroidism and hyperthyroidism. This peaks at about 20 weeks. And as Dr. O'Day will go into the specifics of the study, there's about that coincides with the time that patients are about to go to surgery. So it's really important to be screening for adrenal insufficiency prior to surgery. Our institution has put ACTH and cortisol in our Beacon plans to screen for adrenal insufficiency, just to make sure that that's not an issue, because that is going to be the peak onset right around the time of surgery. Next slide, please.
Thank you so much, Colleen. So the trial that led to the approval was the KEYNOTE-522 trial, and this was patients with high-risk triple-negative breast cancer. So they had to be have either node-positive tumor, or if they were node-negative, have a larger tumor. They had to have a good performance status, and importantly, these patients did not require having their tumor be positive for PD-L1. So whereas in the metastatic setting, this drug is only approved for patients that have expression of PD-L1, in the case of the early stage tumors, the neoadjuvant, it is indiscriminate of PD-L1. Now, that was assessed in the trial, but it wasn't, having PD-L1 positivity was not an eligibility criteria. And patients, you can see here, a little over 1,100 patients were randomized to receive a chemotherapy backbone, which consists of a platinum and taxane, followed by an anthracycline and cyclophosphamide in combination with pembrolizumab, dosed every 3 weeks, compared to the same chemotherapy with placebo. This again was neoadjuvant phase. So during the first part of the treatment, that lasts about 12 weeks. Again, 4 cycles given every 3 weeks. Again, the AC in this trial was given every 3 weeks, only to coincide with the administration of the pembrolizumab, which is every 3 weeks. Then the patients had surgery. and they were not randomized. The patients that received pembrolizumab went on to receive adjuvant pembrolizumab, compared to the patients that received placebo went on to receive placebo. And what they saw in the event-free survival analysis is highly in favor of the group of patients that received pembrolizumab. You see numbers here that are lower than you did with our hormone positive trials. Again, these are triple negative patients that are all high risk, that are all receiving, neoadjuvant therapy. So we see lower numbers, unfortunately, but still an improvement with the addition of the immunotherapy at 84.5% compared to 76.8% for the patients that did not receive pembrolizumab, and that is at 3 years of follow-up. Very importantly, as Colleen mentioned, we can see a wide panel of toxicity with immune therapy. We have also in our own practice, I will share with you, we have seen a greater degree, a higher frequency of immune-related toxicities in our patients, our young breast cancer patients that we are treating neoadjuvantly, than what has historically been reported in other immunotherapy-related clinical trials. Many of these patients are older, have less incidence of autoimmune conditions. For example, in the lung cancer trials, the bladder cancer trials, those are often older patients. Whereas you take a young female population with triple negative breast cancer, we tend to be seeing higher rates of immune-related complications. So very important for us to be aware of that. We can see everything from thyroid dysfunction to diffuse colitis to pneumonitis, pancreatitis. I have a patient with refractory acute kidney injury that is now over 6 months out, and we're still dealing with her acute kidney injury. We have patients that can develop cardiac toxicity in the form of myocarditis. And the adrenal insufficiency is something we have to be aware of, especially for you all as surgeons and people that might be managing these particular patients, understanding if they have received these medications, that they may be at risk for that. Oftentimes, I will tell you, your medical oncology colleagues are not particularly, we're not often recognizing the adrenal insufficiency a lot of the time, because when they are seeing us in clinic, when we're checking their blood pressure, when we're looking at their electrolytes, they're getting steroids as a part of that chemotherapy, which can mask the adrenal insufficiency, of course. So you take a patient that's now 3, 4, 5 weeks out from their last chemotherapy, and you put them under general anesthesia, and you see signs of adrenal insufficiency. It's something that unfortunately can go unrecognized until you're in that anesthesia situation. So just something I want to point out. It's something that I didn't fully appreciate until we started using this agent more widely in our early stage triple negative breast cancer patients.
So I can't stress that enough, because we had several patients where we got into really uncomfortable situations at our surgical center where we were not understanding what was going on, who are on pembrolizumab and who ultimately had acute adrenal insufficiency. We did not have a consideration of why they should have that, but had a lot of very scary struggles in the preoperative timeframe. So as Dr. O'Day and as Colleen mentioned, this is now built, I think, into your plans, where all the patients on this are automatically tested for adrenal insufficiency at certain time points towards the end of their treatment before surgery. So if you have not done that, that would be a great thing to speak to your medical oncologist about. If you all decide not to do that, or you are not going to do that, just keep in the back of your mind, if you have patients on Pembro, this is a big thing that absolutely can happen and absolutely is happening. And so it should also be something that is at the top of your differential if you're having trouble in the OR, because we have had some worrisome things that happen.
Even if the random cortisol or whatever we did to check or screen, it sometimes will be falsely normal because of all the steroids that the patient is getting as a part of their chemotherapy. So sometimes it takes like more time for that to manifest, and that can often be the time at which they're having surgery. So with that, we will pause for any additional questions. I'm going to pull up the chat. I know people have been typing great questions into the chat. If anybody has any other questions, they just want to unmute themselves and ask, or patient cases, clinical scenarios they want to discuss, please let us know. I'm not able to see that.
Yeah, I'll start here. First of all, thank you, ladies, so much. That was fantastic. I can absolutely see why Kelsey was so excited that day, because that was a phenomenal presentation. And yeah, so many gold nuggets for surgeons here. When it comes to some of the autoimmune adverse effects, are those usually transient, or is that something with someone with adrenal insufficiency? Do you expect as they get further out in their survivorship that they're no longer susceptible to that?
So that's really hard because honestly, we don't know. I mean, these agents in the neoadjuvant setting, newly approved, we don't have really long-term follow-up. I can tell you that I personally have a patient that seems to have permanent type 1 diabetes. I mean, we'll see if in 3 years that magically goes away, but as of right now, I mean, there's no sign of that. So we don't know that some of these immune-related toxicities won't be permanent. And it's a really tragic situation. And I can tell you that my own nurse practitioner, who's a triple negative breast cancer survivor, says to me almost on a daily basis when we see these side effects in our clinic, she said, I'm so glad that Keytruda didn't exist when I was a patient. Even though it's better, you know, we see better survival rates and better cure rates, it's scary, you know, when you see cerebritis or, you know, renal insufficiency or myocarditis, you know, so it is just something that we have to be aware of. And we don't know what the long-term implications will be. I can tell you that we have, I think the pendulum has swung, I hope, and I hope you're seeing this in your centers, to giving every possible patient that's eligible for Keytruda to applying it more judiciously to the really high-risk patients. So if I have a patient, for example, with a small, say a 2 centimeter node negative tumor, although they would have been eligible for this trial, I don't usually utilize Keytruda in that patient population because I don't feel the risk benefit makes sense for that particular patient. I save it for my node positive patients, larger tumor sizes, that type of thing. And I know my colleagues are doing the same. So I think it's just something that we have to talk through. And I think for you guys as surgeons, just to be aware of, if you see that on the patients in the patient's chemo plan, or you see that as a part of their treatment, to really be aware of that.
And I'll just add to that, in my experience using pembrolizumab and other immune checkpoint inhibitors in other disease states, usually it's the endocrinopathies that require lifelong treatment. So if we see thyroid disorders, it's something that most patients are going to need to be on thyroid supplementation for life, or adrenal insufficiency. We see it a lot in melanoma patients as well. But thankfully, like colitis and other like
Pneumonitis. Yeah.
and pneumonitis, it requires long courses of steroids. And I think that that's where people misstep often. If you recall, the drug half-life is 22 days. So that's in your system for, several weeks at least, that you need to be on long steroid tapers to treat some of those immune-mediated side effects. But sometimes you need hormone replacement for life, unfortunately.
I will say too, if anyone has a pretty controlled practice and controlled way you're following patients and getting them to surgery if they're on neoadjuvant with these medicines, as soon as we see them going on these medicines, we sort of buckle up and brace for changes in order of things, because honestly, they are great medicines and really unpredictable. And so I have had many patients who have had severe colitis, where the decision has been made to stop treatment quite early. And we've been trying to time high dose steroids for 3 to 4 weeks with when I can get them to surgery and do a safe operation. And there's not an easy way to do this or a good way to do this, but I guess I would say we are just mindful, and we really know when we have these patients that we have to keep a little bit of a closer eye on them in terms of our surgical follow-up and our surgical clinics and whatever route you have with your group and your team that's there. Maybe I can ask this question that was in the chat. Thank you for asking your question. How do you change the discussion for reconstruction versus timing of these medications change if they need radiation after mastectomy due to lymph node disease, given the increased risk of complications with implants and radiation? So as you mentioned, the pembrolizumab can be given concurrently with radiation. So that should not be so much of an issue because it just all proceeds in the same time frame. The CDK4/6, you would do radiation first,
Right.
followed by the CDK4/6. We are not recommending people do total mastectomies because of any of these adjuvant medicines or because of radiation, nor are we recommending implants or TEs come out because of that. We are encouraging our plastic surgeons and trying to work with them on the surgical oncology side to consider more often direct to implants, because we know that the direct to implants cooperate better with the radiation and are more comfortable for the patients. And we're working really hard on the surgical oncology side to make sure our techniques for the skin and nipple sparing mastectomies and things like that are up to par, so that we can kind of set the stage or have that basis so that our plastic surgeons can feel comfortable with that. We don't withhold reconstruction for anyone, even if we knew in advance that they'd be needing radiation, just because of node positive disease. Certainly inflammatory, that's a whole different ballgame, right? But even if we knew that they would need PMRT, we are not in our practice saying that they cannot do reconstruction with tissue expanders or direct to implant. So like I said, it feels sometimes like I'm like the go-between and the translator. And I think that's actually a really good spot and a really good role for us to be in on the surgical oncology side, is to understand the plastic surgery side, understand the medical oncology side, and help to interpret for our partners back and forth.
Any other patient cases or questions that you have about the new medications or any of those? There are more agents that are coming in the HER2 positive space. There are many trials that are ongoing right now. So we're all used to the adjuvant, you know, Herceptin, Perjeta, Kadcyla. There are large clinical trials right now that many of us anticipate to be positive, where we combine a small molecule tucatinib in the adjuvant setting, and that can have other side effects, you know, and that potentially could be given in combination with the T-DM1 if that trial is positive, which many of us expect that it will be. So there's just going to be a continuous evolution of how I feel like we went through this period, maybe from the time I was in my fellowship to the time about the time I came back to KU, in which things were pretty stable in terms of if a patient needed neoadjuvant, okay, what they needed for adjuvant, endocrine therapy, very cut and dry, very straightforward. And now, literally every few months, there are major changes in the adjuvant therapeutic options. And so I think most oncologists are not up to date on this. So it's not that we expect all of our surgical colleagues to be. We just want you to have a familiarity with these medicines so you feel comfortable and you at least recognize, oh, that's one of those medicines I recognize that could have implications on their surgery. Let me pick up the phone and talk to the medical oncologist or whatever that looks like for you. But I think just to have an awareness about it and to not really promise that patient, oh, I'm going to go ahead and pencil you in for your DIEP flap, you know, 3 months after your surgery when you still need radiation. We would like to get you at least started on these medicines and get you used to it. And I should say one of the pearls that we have learned in the adjuvant CDK4/6 inhibitors, particularly the Verzenio, patients feel better and do better the longer they're on them. So they have less GI toxicity, less diarrhea, the longer they're on them. So I don't really want a patient in the middle of grade 3 diarrhea trying to recover from a DIEP flap. I mean, that's just not even kind. I mean, that's not something I want a patient to go through. So if I could have a patient for say 4 to 6 months on their Verzenio, they're used to it, they're tolerating it, we feel comfortable with it, their patient's managing, and then going to a DIEP flap, to me, that's a much more acceptable option than trying to push the patient and then, you know, seeing, you know, complications in terms of trying to manage the overlapping toxicity. Does that make sense to everyone? Okay. Okay, and I think you put in your email, and my email I'll put in there as well. If anybody ever has any patient they just want to discuss or collaborate or run by or see if we have a medical oncology trial here at KU, we would love to discuss that with you. We definitely want to be a resource for you as you take care of patients across the state, and we're grateful for all of you. I know how hard it is to be in community practice in other areas, and I appreciate every day what you all do. And so again, we very much want to be a resource for you if we can.
And if you feel like you don't have the answers, we don't either, but at least we can tell you what the conversation is and how we're trudging through the mud together and kind of what direction we're going in maybe. So
All right, this was just absolutely fantastic. Thank you all so much. I think what we'll do in follow-up is, Mary Beth, maybe to all the attendees, we could send a follow-up email that includes the link to where the video can be found. I know I'm very excited to be on call this weekend because I'm going to have to watch this again and go through all the nerding out mechanism slides. And we'll likely have more questions after that. And thank you guys so much for being willing to answer questions through email and follow up after that. A big thank you to KUMC AHEC, Area Health Education Center, and Mary Beth